Multi-drug resistant TB, as mentioned. So I'll be talking a little bit about multi-drug resistant TB treatment guidance, and specifically the last 4 to 5 years, the shorter course MDR-TB regimens that have been studied and have been advancing rapidly. So multi-drug resistant TB is resistant to isoniazid and rifampin, which is generally the backbone of first-line TB treatment. Rifampin monoresistance is generally classed with multi-drug resistant TB, since the treatment of rifampin resistant TB is very similar to multi-drug resistant TB. And the widespread use of gene expert testing, which allows rapid identification of many rifampin-resistant isolates, has increased the early detection of rifampin-resistant TB, and often that is treated empirically as multi-drug resistant tuberculosis. So worldwide, in 2022, 410,000 people were estimated to develop multi-drug resistant TB, which is about 3.3% of the total worldwide TB burden. Extensively drug-resistant TB is an increasingly present version of MDR-TB. It's MDR-TB plus resistance to any fluoroquinolone, levofloxacin or moxifloxacin, and at least one additional what's referred to as Group A drug. You'll see these classifications in a few minutes, specifically bedaquiline or linezolid. And pre-XDR-TB is MDR-TB plus resistance to fluoroquinolone. So 2019, American Thoracic Society and Infectious Disease Society of America issued MDR-TB guidance using individual patient data across 25 countries. And that was updated in 2022 and 2023 for provisional guidance on the use of bedaquiline-based regimens, specifically bedaquiline, protomidate, linezolid, and bedaquiline, protomidate, linezolid, and moxifloxacin. WHO in 2020 also updated their prior guidance addressing new shorter regimens. So we'll be talking a little bit about that. So from the original recommendations, the guidelines suggested that you choose from this list of medications. So you wanted a fluoroquinolone, so levofloxacin or moxifloxacin, bedaquiline and linezolid, and you wanted 5 total drugs. So you selected from the following list depending on availability and side effects: clofazimine, cycloserine, an injectable such as amikacin, delamanid, ethambutol and pyrazinamide if sensitive, and going way down the list to ethionamide, imipenem, meropenem, some of the more infrequently used drugs. So needing a lot of medications on board from the old guidelines. So first, the STREAM trial in 2019 looked at a 9-month regimen as opposed to the prior recommended treatment durations, which were 18 months or longer. But this 9-month regimen contained a lot of medications. So this was 7 drugs over 4 months, and you might consider for 5 to 6 months if smear conversion was delayed. And then you continued with 4 drugs times another 5 months. So in that arm used kanamycin, prothionamide, isoniazid, moxifloxacin, clofazimine, ethambutol, and pyrazinamide. And then the arm that compared it to a 20 to 24-month regimen in arm 2, looking at age over 18, and they followed for 2.5 years. And followed for culture negativity at 132 weeks after initiation. So in general, the rates of favorable outcome were relatively equivalent between the 9-month regimen and the longer regimen. But there were quite a few high-grade adverse events in both arms and a slightly increased death rate in the shorter arm. And there was an increased rate of acquisition of fluoroquinolone resistance. So it drastically reduced treatment time, but it had a very, very high number of drugs and a high side effect burden. So initially, some modifications were made on those initial studies. In the 2020 WHO guidelines, they suggest the use of bedaquiline rather than the kanamycin. And in 2021, South Africa reported programmatic use of linezolid as opposed to some of the ethionamide that had been used, both of which were easier access drugs at the time and showed equivalent outcomes generally within the programmatic use. And then new studies came out looking at what we now use relatively frequently in the treatment of MDR-TB, BPAL, the NICS-TB trial. So this targeted the hardest to treat TB, either XDR-TB or refractory to treatment NDR-TB. Of note, it's not a controlled trial. This is a single-arm prospective cohort. So no control group was present in this trial. So all comparisons are made to what is known about the treatment outcomes of XDR or refractory MDR-TB. So this was bedaquiline, protominid, and linezolid, with the linezolid dosed at 1,200 milligrams daily for 26 weeks. They also allowed extension of the sputum, if the sputum culture was still positive at 16 weeks, to extend the duration to 9 months. They included all outcomes, including people who had to terminate or reduce the dose of linezolid due to side effects, which was very helpful because essentially 100% of the patients in this study had some type of side effect, almost always from linezolid. But as you can see, despite that fact, the timed unfavorable outcomes, there weren't that many unfavorable outcomes in this study. 90% of the patients had a favorable outcome at 6 months after the end of treatment, which for this category of disease was an extremely good outcome. And generally speaking, time to sputum culture conversion was almost always under the 16-week threshold. So as I mentioned before, 100% of the patients had some type of adverse event in this study. 57% experienced a grade 3 or higher adverse event. Peripheral neuropathy and myelosuppression were extremely prevalent, and almost all were related to linezolid. 85% of study participants could not maintain the 1,200 milligram daily dosing for a total of 6 months. Despite this, they still had the excellent outcomes. And so this did quickly become a favorable option for the treatment of multi-drug resistant TB. But due to the complications of linezolid, next up, the XENIX trial looked at various different linezolid dosing options to try to help mitigate those side effects. So they compared linezolid 1,200 for 26 weeks or for only 9 weeks of the duration. And then they also looked at linezolid 600 milligrams a day for either the entire duration or for 9 weeks. And again, looked at the primary endpoint of an unfavorable outcome. So as you can see here, in general, still mostly favorable outcomes within many of the arms. The 600 milligrams for 9 weeks had a slightly lower favorable outcome rating. But as you can generally see, although there was better tolerance of the 1,200 milligrams times 26 weeks of linezolid in this group, the 600 milligram dose was tolerated much, much better, with 13% requiring modification of the dose as opposed to 51% in the main arm. And this led to a general trend of using 600 milligrams per day of linezolid for this treatment. After that, looking to expand on this this new regimen, Médecins Sans Frontières enrolled TB Practical, which looked at several different regimens using the BPAL as a base. So they looked at BPAL itself, BPAL plus clofazimine, and BPAL plus moxifloxacin. Looked initially at primary outcome measures at 8 weeks of treatment in terms of culture conversion. And when BPAL plus moxifloxacin performed the best there, they compared it directly to the standard longer regimen. So this time with a control group of the standard of care treatment, which the NICS trials had not had. So as mentioned, BPAL plus moxifloxacin, 24 weeks as opposed to the XENIX of 26 weeks, bedaquiline, protominid, moxifloxacin, and the linezolid at the 600 milligrams per day dosing for the first 16 weeks. And then they actually dropped to 300 milligrams daily after that point for the final duration of treatment. And the results were quite dramatic. So 89% of patients in the BPAL-M arm had favorable outcomes, 20% had side effects, and there were no deaths, as opposed to the WHO prior standard of care, with 52% of patients with favorable outcomes and almost 60% with side effects. So this trial was, for the first time, had a direct comparison with the new bedaquiline short course regimens and the old long course regimens, and was extremely good outcomes. So this was adopted relatively quickly. The US initially started using this treatment in October of 2019. And recently, in the last year, a paper in CID was released showing the experience of 68 patients treated within the US with this regimen. In general, the outcomes in the US have been favorable as well. There's been 2 out of the 68 patients described experienced relapse. About 10% required some type of dose adjustment in the dose or frequency of linezolid due to adverse events. Age range used down to age 14 or as old as 83. HIV and other immunocompromising conditions were relatively rare, however. Now, previously, most of the studies have been performed in pulmonary TB. This experience has been extrapolated some to extrapulmonary TB. No CNS disease was described in this cohort. There have since been some case reports of the use of BPAL or BPAL-M in patients with CNS disease, but the CNS penetration of bedaquiline and protominid is not well described. So that remains still case reports rather than full studies. Also, although this is a predominantly an MDR TB treatment trial, I would be remiss in not noting that there has been recent evidence in what to do with the contacts of people with MDR TB. TB Champ and VQuin recently had results released of levofloxacin for 6 months as treatment of contacts of people with multi-drug resistant TB. TB Champ looked specifically at children. VQuin looked at household contacts of any age, and both of them showed roughly a 50% reduction in the development of active TB over 18 to 24 months. But most importantly, both showed that the drug was very safe over that time period. So we've long used levofloxacin in contacts of people with known multi-drug resistant TB, but for the first time, we have some evidence to put numbers in front of our patients. So I'd like to acknowledge CTRAC. Thank you so much for having me for this talk, and thanks to Dr. Masta Narita for provision of many of these slides. Thank you so much.